sir. Respected Chairperson-elect, Dr. Sanjeev Rawat, sir. Today's session moderator, Dr. Mrityunjay Pao, who is our executive board member and also intensivist with a special interest in pediatric pulmonology. Our faculty, Dr. Rasmi Ranjan Das and Dr. Joseph Matthew. Dr. Joseph Matthew would be joining a bit late because he is in other webinar. So may I request our session moderator for today's session, Dr. Mrityunjay Pao. He is consultant in Sanjeevani Hospital at Jorhat, Assam, to introduce today's speaker. And before that, I would like to ask our chairperson, sir, for formal welcome message. Over to Kalpana, sir.
Yeah. Good evening, all. So, at the outset, I take this opportunity to welcome our President-elect, Dr. Sanjeev Singh Rawat, sir. And I take this opportunity to welcome the Honorable Secretary, Dr. Jagdish Goyal, and all the office bearers of IAPNRC and executive board members for today's the most important session of World Pneumonia Day. We have a very eminent personalities for today's talk. That is none other than Dr. Joseph Matthew. Sir is going to talk about RSV recent advances. And also we have another eminent personality, young budding pulmonologist. And he is very familiar with all of us. And he is none other than Dr. Rasmi Ranjan Das. He is professor in AIIMS, Bhubaneswar. He is going to deliver a talk on what is recent advances in pneumonia. And the whole session is moderated by our executive board member, that is Dr. Mrityunjay Pao. And I welcome all of you for this session. And I also welcome all invitees, all delegates, and whoever has joined the session. And this is the most important activity of the chapter. And every year we are spreading awareness and creating a lot of, the interest in the pneumonia. And this is one of the dreaded killer of under five children. And in this context, so the chapter has made every attempt to create what is most important for today's, the practitioners and the postgraduates, so that they keep on alerting regarding pneumonia, so that every one of us give the utmost important treatment to all the needy children across the country. And with these few words, I welcome you all for these sessions, and I hand it over to Dr. Jagdish Goyal.
Thank you, sir. Thank you very much. So, theme of World Pneumonia Day for this year is every breath count. Let us fight together. Let us fight pneumonia together. So, with this theme, we have planned a session in such a way that means, as told by Kalpamar sir, that postgraduate as well as general pediatrician as well as pediatric pulmonologist might be aware what are the new in pneumonia management. And we are also trying to highlight one important etiological agent of pneumonia, that is RSV. So Dr. Joseph Matthew sir would be speaking on RSV pneumonia. So now I would like to request our moderator, Dr. Mrityunjay Pao, to introduce today's faculty and start the proceeding of webinar. Over to Dr. Mrityunjay.
Thank you, Dr. Jagdish. Thank you very much. Respected Kalpana sir, our chairperson NRC IAP 2024, and NRC IAP chairperson-elect Dr. Sanjeev Singh Raut sir, I would like to welcome you also. I can see Dr. Joseph Matthew has also joined. Welcome, sir, to this discussion on World Pneumonia Day. So today we have got very important topics and two very interesting topics on pneumonia. One will be by Dr. Rasmi Ranjan and Dr. Joseph Matthew. So first of all, I will share my screen. I will try to show the CV of Dr. Joseph first. Can you see the full screen? Hello?
No, sir, it's not in the full screen, I think.
Okay, anyway, yeah, actually, because of the IP, okay, Apple computer, I will just read out the introduction. Dr. Joseph L. Matthew is professor and head of pediatric pulmonology division at PGI Chandigarh, and he is a renowned academist from Advanced Center of Pediatrics, PGI Chandigarh, and he's MD and PhD and fellow in pediatric respirology. He is a quite well-known figure in pulmonology all over India. He's got a special area of interest in pediatric pulmonology and evidence-based practice and biomedical innovation. And Saurabh has got a sharp knowledge in the field of in the field of research methodology. So he's an excellent teacher also. I recently had the fortune of hearing to his talks during the IP vaccinology, and he's got a very different way of looking at things. Welcome, sir, Dr. Joseph Matthew. And the other speaker today is Dr. The other young and budding pulmonologist, Dr. Rasmin Das. He's the professor of pediatrics, and he heads the division of pediatric pulmonology and intensive care at the Department of Pediatrics at AIIMS Bhubaneswar. He's quite well known. He's the upcoming speaker. He's very well known. He has got many awards. I won't read them out. And his achievements are well known to us, and he's has presented papers worldwide, and is well known throughout the nation. Area of interest is pediatric pulmonology, infectious disease, and he is very keen and has got good interest in evidence-based medicine and guideline development. And he has more than 150 publications in index journals. So this is the brief introduction of the eminent speakers today. So I would like to first invite Dr. Rasmi Ranjan to share his screen and start the talk on recent advances in pneumonia and treatment. Welcome, Dr. Rasmi.
Sir, is my screen visible?
Yes.
Am I audible?
Yes, you are.
Thank you so much, sir, for this nice introduction, and a very good evening to respected Kalpanavar sir, Dr. Jagdish Bail, Rawat sir, and to you, sir, and all the delegates, and greetings on this occasion of World Pneumonia Day, because we have united for a cause, and the purpose is to spread awareness, because there are many kind of knowledge gaps that still persist in pneumonia, and that make pneumonia still a leading killer in children. So we should take utmost care to diagnose and provide appropriate treatment. So with this kind of background, the IAPNRC has planned this webinar. And the topic assigned to me is recent advances in diagnosis and management of pneumonia. So I will cover it in two parts. So advance, sometimes it is necessary. And all of us are remember this RG case, Kolkata. And when the primary investigation by police was kind of failed and didn't reach any conclusion, then CBI came into picture. And even if the crime scene was altered, they used the 3D laser mapping to kind of get the clues. And ultimately, they have made remarkable progress in this case. And hopefully, the case will be solved soon. So with this background, let us come to the today's topic, that is advances in diagnosis. But before that, we should know why this pneumonia is very, very important. So pneumonia is important in two ways. First, it has a short-term implications and long-term implications. Pneumonia is still the leading cause of childhood mortality and morbidity and hospital admission, even after the advent of these pneumococcal and H influenza vaccines. And long-term complications include reduced lung function and development of chronic non-communicable diseases like asthma and COPD. So these are the long-term complications. So it is not like that once the child recovers from pneumonia, he is fine. So he may face also long-term complications. So we have to be very, very careful. And we have to kind of keep the child in the follow-up to see what are the complications developing in the future, let's say in the adulthood. Second is we should know the etiology, because the ultimate aim in pneumonia management is to know the etiology, so that you can employ different diagnostic modalities to catch up the etiology, because ultimate aim is to give part antibiotics and up to how many days you have to give, what are the complications, how you can prevent, and how you can decrease the morbidity and mortality. So if you see in last 40 years, almost there is a paradigm shift in etiology of pneumonia. In 1980, before the advent of this pneumococcal and asyncytial vaccine, these were the two most common agents for childhood pneumonia, almost in more than 50% cases. But recently, it has been found that viruses constitute almost 70 to 80% of cases, and bacterial, they contain contribute to the minuscule, let's say 10 to 20%. But in most cases, there may be kind of mixed infection. So viruses are emerging as the most common cause, and there are different viruses. So in this image, as you can see, I have taken this from a very recent article that was published in Clinical Infectious Disease. So they have divided the etiology as per the different age category and as per the viral and bacterial causes. So let us discuss what are the viral causes. So if you see in children less than 4 years, RSV is still the leading cause of pneumonia. And the second most common cause is the human rhinovirus. But if you see in children more than 5 years, human rhinovirus is the leading cause of pneumonia. And among the bacteria, Streptococcus pneumoniae, that is the most common cause in children less than 2 years. And after 2 years, you'll be surprised to know that this Mycoplasma pneumoniae is a leading cause. So whenever a child is getting admitted and is not responding to conventional antibiotics, and you are not getting any kind of consolation, typical bacterial pneumonia picture, so you can think of Mycoplasma pneumoniae, you can send the appropriate investigation, and if required, you can start also azithromycin or some kind of drug to cover these organisms. So then coming to the today's topic, what are the advances in diagnosis of childhood pneumonia? So broadly, I'll be discussing like under different headings, like what are the imaging modality, and there are the kind of telemedicine facility also that is upcoming. So doctors sitting in kind of in remote places also, like they can take help of the specialty in medical colleges or in district headquarters hospitals and diagnose a case of pneumonia. They can send the imaging and they can discuss also. And now there are e-stethoscope in which you can record the different sounds from the chest that can be interpreted, because when the child is crying, it is very difficult to know whether it is crepitations, crackles, or whether it is a wheeze that is mimicking crackles. So interpretation of sound is very, very important. And so that can be recorded by this e-stethoscope. And out of the imaging modality, point of care ultrasound is the emerging one. It has a kind of large role because it is easily available. It is portable. There is no risk of radiation exposure. And in addition, it can tell whether there is pneumonia or the patient is having any complicated pneumonia. And you can take the samples also. Suppose there is a complicated pneumonia, you can take the samples, you can put the chest tube. So everything. So it can be both diagnostic and therapeutic in cases of pneumonia management. And it has been found that it is better than X-ray. And suppose you are not able to know what is there in the ultrasound or something is there, what is the lung necrosis or any kind of complications. So you can also do a CT or MRI. MRI is another imaging modality that I will discuss. So these are the imaging modality that have found their role in children with different severities of pneumonia, whether it is non-severe or severe or complicated pneumonia. Then you can also isolate the organism from different body fluids, and those body fluids you can take from the upper respiratory tract that include pharyngeal swab, nasopharyngeal aspirate, and you can employ the PCR or antigen detection assay to isolate the organism, like the viruses, Mycoplasma, chlamydia. So those can be isolated from this nasopharyngeal aspirate. And the low respiratory tract samples, you can take induced sputum by nebulizing with 3% saline or something like that. If the child is expectorating, then it's fine. You can collect the samples. Tracheal aspirate if the patient is intubated. Bronchoalveolar lavage that you can take. Long biopsy is not employed nowadays. It is an obsolete modality. And if the child is having complicated pneumonia, you can take the pleural fluid also, and you can employ them to gram stain culture, PCR, and antigen detection assay. Blood, you can send the blood for culture, PCR, ELISA, or any kind of antibody if you are suspecting a particular organism, that can be done. There are different spot assay like ELI spot assay, so that can be employed. And some organism antigen can be detected in the urine like Legionella. So coming to the ultrasound in pneumonia, because it is an upcoming modality, and many centers have started using upfront in cases of pneumonia. So what is this ultrasound basically? So all of us know, so this uses kind of your piezoelectric crystals, and the vibration is created, and that can be detected through different probes. So the probes may be convex, curvilinear, or your linear array-based probes. So as you can see, so these are the different images. So when you put the probe and over the kind of intercostal space, so as you can see, so the vibrations will transfer to the lungs. So here you can see there are horizontal lines beneath the pleura. So these are the A lines. So A lines indicate the lungs is normal. In the second image, you can see there are cometal appearances. Okay, so these are the vertical lines that is kind of emerging from the pleura. So these are the B lines, and B lines indicate there is some pathology. So there may be fluid in the lungs, there may be fibrosis, or there may be consolidation. So in these conditions, so you'll see the B lines. Then the third image is that of the consolidation, as you can see. So here, if you see, the lungs is looking bit hypoechoic. So why the lung is hypoechoic? Because there is hepatization. So the consistency like that of the liver or spleen, and you can see some dotted kind of white spots over here. So these are the basically air bronchograms. So in a hypoechoic lung, if you are seeing air bronchogram, that indicates it is consolidation. So compared to X-ray, the ultrasound images are almost opposite, you can tell, because in ultrasound, the fluid will look black, that is anechoic. But in X-ray, it will look white. And air will look black in case of X-ray, but it will look white in case of ultrasound. And soft tissue, it will look almost hypoechoic in both X-ray and ultrasound. So that you have to remember. So you can also learn from experts, and it is a very good test. As I told, there is less risk of radiation exposure, and you can easily know whether it is a simple pneumonia, complicated pneumonia, whether there is a cystic lesion, and you can aspirate the fluids also. So this is a child, a 6-year-old, and who presented with cough, breathing difficulty. X-ray was done. As you can see on left side, there is a haziness in the middle and lower zone, and nothing was clear from this, like whether it is a kind of pneumonia or there is underlying effusion, though the CP angle is looks blunted here. So then the child was subjected to ultrasound, as you can see in the second image. So the lung, this one, the shadow is decreased, so it is a hypoechoic lung, and you can see there are linear shadows, whitey shadow, that is arrow mark. So these are the air bronchograms. So that means there is underlying lung consolidation. If you see in the third image, so when the probe was moved laterally, you can see there are multiple loculations. So you can see the arrows here, and I told the fluid will look black in case of ultrasound. So you can see there are loculations inside which there are black shadows. So these are the fluid. So probably it is a case of complicated pneumonia. So from the X-ray, we are not able to know whether it is a simple or complicated pneumonia, but by doing the ultrasound, you saw that it is a complicated pneumonia. So if there are loculations, of course, this child will require chest tube drainage in addition to your antibiotics. So a systematic review has done comparing chest X-ray and focus in pneumonia, and as you can see, the sensitivity specificity of ultrasound is much more than that of the chest radiography. So that's why it is an upcoming modality, and whenever there is facility available, you should subject the child to ultrasound, in particularly whenever we are planning to admit the cases. Then another imaging modality is MRI. Okay, so MRI is an upcoming modality. The experience is very, very less. Only few centers are using. The problem with MRI is that the patient need to be kind of still, like the patient should not move because it will produce some artifact. And there should be breath holding, because if there is a not breath holding, then the images will be poor quality and it will be very difficult to interpret. So, and in addition, MRI will take almost 40 to 45 minutes. But there are some rapid sequence MRI, so that can finish the scan within 10 minutes. So in the kind of in future, they will be available, and that will be a dramatic kind of, you can tell, progress in diagnosis of pneumonia. And the advantage of MRI is that it will produce 3D image like CT, and without any radiation exposure, and it may be better than ultrasound and CT, and it is of course much better than chest X-ray, which produces 2D images, particularly in case of complicated pneumonia. And out of the T1, T2 sequences, because MRI has two main sequence, that is T1 and T2 weighted images. All of us are aware regarding this MRI of brain, so same T1, T2. So T2 sequence in chest is very, very useful. We'll discuss one or two case scenario. This is one child, 7-year-old girl, who presented with fever and cough for a week. She was already on oral antibiotics. Now her condition is worsening with increasing breathing difficulty since last 3 days. And on examination, there were coarse crepitations in the left infrascapular region. So you see the MRI and X-ray images are here. First, let us look at the panel C. So if you see, there are some opacities, heterogeneous opacity. They are in the left lower zone of the chest, and CP angle a bit visible. Probably there is not much fluid. And then MRI was done. So A panel is the T1 weighted image, panel B is the T2 weighted image. So you see in the panel A, so there are kind of two large kind of lesions with a hypodensity in the T1, and in panel B, that is the T2 weighted image, you can see. So it is hyperintense. So that means probably there is some underlying necrosis or abscess formation. So now if you see the X-ray, you cannot tell whether it is abscess or a necrotizing pneumonia because there are heterogeneous opacities. But here there are two large abscesses. So that means this child needs admission and he needs coverage of organism that causes this pulmonary abscess. Because if you don't do MRI in this case, then what will happen? You may not be able to know. Ultrasound can also detect this abscess. So if the facility are available, so you can do the ultrasound. MRI, as I told, it is upcoming modality. I'm just showing you what additional benefit MRI can provide in a given case. So this is another case, a 9-year-old child with complicated pneumonia. He received IV antibiotics for 2 weeks, followed by oral antibiotics. In follow-up after 4 weeks, the child was better, but occasional low-grade fever was persisting. There was occasional fine crepitation in right infrascapular area. So you see, there are 4 panels. So panel C is the first X-ray done. You can see there are some haziness. In the right, you can tell lower zone mainly and part of the middle zone. And at the same time, MRI was done. You see there is an abscess over here. So this abscess was not visible in case of X-ray. And after 4 weeks, if you see, X-ray is entirely normal. In panel D, this shadow has totally disappeared. But if you see the MRI, the abscess is not totally disappeared. So that means this child needs additional kind of prolongation of antibiotics. So you cannot stop the antibiotics here because still the abscess is persisting. So many children who present with recurrence of symptom, probably we do X-ray, it is normal, we send, but probably the pathology is still there, that is not totally cleared from the lungs. So then the MRI versus ultrasound in pneumonia, which one is better? So this is another case scenario, 3-year-old child with fever, cough and shortness of breath for 7 days. On examination, there were coarse crepitations in right mammary area with decreased air entry. So X-ray, MRI and ultrasound were done in this case. So you see panel B, that is the X-ray, that is showing some opacity, homogeneous opacity, that is aborting the right major fissure and aborting the kind of, you can tell, right cardiac border. Okay, so probably it looks like a consolidation. Ultrasound in panel C, as you can see, the lung is hypoechoic, red arrow mark. So probably it is a consolidation on ultrasound. But when you, the MRI was done, as you can see in panel A, there is a kind of demarcation which is there. If you see, there is a kind of clearing around a central area which is looking hyperintense. So this is a T2 weighted image. So the MRI diagnosis was this is a pulmonary abscess. So now you can see on X-ray you are seeing it is pneumonia. In ultrasound it is pneumonia, but in MRI it is a long abscess. So in that way MRI can be very, very useful. And sometimes you can see the patient, you started antibiotics, but he worsened. So probably there was something which we missed actually. So this MRI in these cases can provide additional diagnostic clues without any radiation exposure. So then digital stethoscope, as I told, so you can record the sounds, you can analyze later because the sound will vary as per the underlying pathological condition. So even it can be used for teaching and learning purposes. And if you want to keep the data also, if you are planning some study on pneumonia, you can keep that. Okay, so for quality control purpose, you can also use this digital stethoscope. Then let us discuss regarding the body fluids. So out of the body fluids, we discussed regarding the throat swab, nasopharyngeal aspirate. So most of the time they are used for the isolation of viruses. But still you can use them to isolate bacteria, but chance of a typical bacteria isolation is very, very less. You can get some atypical one or some colonized like streptococcus and all those. So what next you can use for bacterial isolation is induced sputum. So there have been different studies conducted regarding induced sputum, and the results are conflicting. So this study found that pathogens from pediatric induced sputum reflect oropharyngeal caries and is insufficient to determine bacterial etiology of CPAP, community-acquired pneumonia. So they told that probably the induced sputum is not helpful in case of community-acquired pneumonia. This is another study that was a very kind of large study recently published, but they found that induced sputum is an adequate sample for diagnosis of community-acquired pneumonia. So what does it mean? That means we have to test the accuracy of induced sputum in different settings. So these are the studies that have shown us the fact that more research can be done regarding induced sputum in community-acquired pneumonia, but as of now, we cannot blanketly recommend this. But whenever you are not getting an additional organism from different sources, so you can also use. Then bowel fluid analysis. So if the patient is intubated, you can use this bowel fluid. If the patient is stable also, you can do this bronchoscopy and take the bowel. And in intubated patient, you can aspirate the fluid without doing the bronchoscopy, and that is known as mini bowel. So this is one of our case. The child present, this is an 11-month-old boy who presented with recurrent pneumonia. He was admitted 2-3 times outside. When he presented to us, the child was having severe pneumonia and he got intubated, and we sent the bowel sample. As you can see, it grew Pseudomonas aeruginosa. So as it grew Pseudomonas aeruginosa, so a possibility of cystic fibrosis escaped because the child was having recurrent pneumonia. And the genetic testing was sent, and it was kind of positive for the cystic fibrosis gene. So the diagnosis was cystic fibrosis. So bowel fluid can help you in making some diagnosis and also give you the clue regarding the etiological agent or the underlying pathology whenever you are not able to isolate the bacteria from other sources. Because this child was admitted multiple times outside, every time the culture was sterile, so he received multiple antibiotics, he will get okay, and again he will have the recurrence of symptom. So then next generation sequencing. So this is also an upcoming modality, and it has usefulness in various other diseases. And few studies are there on NGS in complicated pneumonia. Why it was tested? Because all of us know blood and pleural fluid culture has poor sensitivity in complicated community-acquired pneumonia. So NGS has increased sensitivity versus traditional culture-based methods, and it is less influenced by prior antibiotic treatment, because many children, they will receive antibiotics, and whenever you send culture, you will not get anything. So in those cases, NGS can be employed, but there are some key limitations. The first limitation is determination of susceptibility of the identifier organism. That means you have to still do the AMS, that is the antimicrobial sensitivity pattern, even if the organism you are detecting in NGS. Then second is potential for identification of organism without clinical significance. That means you get some organism which may not be responsible for the current illness in the child. Third is it should be limited to complicated cases to avoid waste and incidental pathogen identification. So you show you so many organisms, and it will be difficult to know which one is actually responsible for this pneumonia in the given child. Then this multiplex PCR, this is a kind of, you can tell, a kind of widely employed, particularly in private sectors, because these are very costly tests. And the recent is the BioFire Film Array Pneumonia Panel that almost targets 33 organisms, viruses 8, bacteria 18, and it can also simultaneously detect the antimicrobial resistance gene. That means you will get the organism and their sensitivity pattern. So in severe cases, complicated cases, or where the child is not responding in ICU cases, so these tests are useful. And they can be done on almost multiple samples like bowel, sputum, even mini bowel. And studies have shown that their sensitivity specificity is very, very high. Almost, you can tell, more than 95%. But there are some limitations because the cost is very, very high. Patient has to spend almost 12 to 15,000. And in government setup, it is very, very difficult. It is an add-on test. So you have to also do the subculture, and you have to do the antimicrobial sensitivity pattern, because what it shows may not match with your kind of lab report. So that you have to see. And suppose it is detecting multiple organisms, then it is very difficult to know which one is actually responsible. And sometimes it may be may not identify all pathogens in mixed infections, even if they are in the panel. And false positive results are also there, and you have to correlate with gram staining. And last point is that the ability to predict the susceptibility of gram-negative bacilli is imperfect. So what it shows may not be actually true. The patient may not respond to the antibiotic that it has shown it is sensitive or resistant. So that's why you have to be careful, particularly in case of gram-negative bacilli. Next is regarding the biomarker. So many biomarkers have been tested because it is very important to know whether the child is suffering from bacterial or viral pneumonia. Because if it is virus, you are not going to give antibiotics. And if it is bacterial, of course, you are going to give antibiotics. So many biomarkers have been tested, as you can show in this image. And their usefulness still is not clear. And still we are waiting to get a kind of POC, that is the point of care biomarker that can help differentiate bacteria or virus at the outset, so that this antibiotic stewardship can be kind of properly employed in clinical practice. So this is one of our study, and in which we tested this procalcitonin diagnosis of community-acquired pneumonia in children. And this was a multi-center study, almost involving 6 centers in India. And what we could find that procalcitonin may not be useful in diagnosis of your non-severe community-acquired pneumonia. And in severe pneumonia, the levels are high. So again, you are not sure based on a particular level whether the child is suffering kind of severe pneumonia and what could be the possibility, because it is very, very important that you should know the possibilities. So that PCT cannot tell. So, but it has been shown that the levels are very high in severe pneumonia. So any child who is coming, you have done a PCT, levels are high. So probably the child is suffering from severe pneumonia, but it is not a linear relation. So, and the levels kind of cutoffs vary from lab to lab. So there is no single cutoff that is applicable to all the setting. And in addition, you have different kind of labs that use different kit to detect the PCT. Somewhere it may be more than 0.2, which is significant. Somewhere it may be more than 0.5. So the conclusion is that PCT is not a very useful modality in children with community-acquired pneumonia. Then role of oxygen saturation monitoring. So kind of there have been many papers, particularly from the African countries, and some papers are from India also. And it has been shown that saturation monitoring is a very useful, and it helps in classification of the severity at the outset, even in outpatient setting. So you can monitor for the SpO2, and if SpO2 is low, so probably the child is suffering from severe pneumonia, even if the child is not showing distress or the child is looking stable. So in our study, again, this was a multi-center study, and we found that addition of SpO2 of less than 92% to chest indrawing or the WHO clinical criteria increase the probability of pneumonia diagnosis. So if there is a chest indrawing, there is a hypoxemia, that means probably the child is suffering from pneumonia. And the hypoxia documentation is very, very important, because if the child looks stable and there is hypoxemia, that means the child needs admission. So then coming to the advances in management. So always there is a confusion which dose to use. Some tell let us use the high dose, low dose. There are a lot many confusions. And what is the duration, whether to use for 3 days, 5 days, 7 days, 10 days. So this is the IAPNRC that was published in JAMA. And the authors concluded that among children with community-acquired pneumonia discharged from an emergency department or hospital within 48 hours, further outpatient treatment with oral amoxicillin, it is not amoxiclav, at 35 to 50 milligram per kg per day was non-inferior to 70 to 90 milligram per kg per day. So that means you can use the low dose. And duration, 3 days was non-inferior to 7 days. So for non-severe pneumonia, you can use at a dose of 35 to 50 milligram per kg per day for 3 days, that is enough. And this is another systematic review that was again published in JAMA Pediatrics that compared short versus long duration of antibiotics in non-severe pneumonia, and the result was same. That means 3 days was non-inferior to 5, 7, and 10 days. So there is no point in using a longer course. So there have been few studies on this steroid in community-acquired pneumonia, many studies in adults and few studies in children. And this was the Cochrane review that included almost 17 studies, RCTs, 13 were on adults and 4 were in children. So the authors concluded that corticosteroid therapy reduced mortality and morbidity in adults with severe community-acquired pneumonia. Corticosteroid therapy reduced morbidity but not mortality for adults and children with non-severe pneumonia. So in
Dr.
adults,
Dr. just sorry to interrupt you. 5 more minutes, huh? 5 minutes more. Huh?
Two more slides. Sir.
Yeah.
So that means corticosteroid will reduce mortality morbidity in adults with severe pneumonia, but it doesn't help children with severe this non-severe pneumonia or severe pneumonia. So steroid as of now cannot be used in children, though it can be used in adults with severe pneumonia. And again, there is a lot of debate regarding whether any role of zinc, vitamin A, vitamin D. In our PG days, I could see Nelson mentioning that in acute pneumonia, zinc can be used, and the dose was written, what I could remember at that time, 10 milligram per day. So probably it is not useful. And after that, we published one systematic review in 2012 that found that zinc has no role in children hospitalized with severe acute pneumonia. So we should not use zinc. And this was our Cochrane review that tried to find out any role of vitamin D in children with the pneumonia, acute pneumonia. Again, there was no role. And still there are trials ongoing, and in future we can get an answer, but I don't think these are useful agents. And vitamin A in pneumonia studies are there. Again, that shows there is no benefit. So these zinc, vitamin A, vitamin D should not be used in children with pneumonia. So coming to the last slide. So what are the take-home messages from my presentation? So point of care ultrasound is emerging as the first line imaging modality in pneumonia. So whenever it is available, you should do. As I told, what are the advantages? MRI chest further role in complicated pneumonia cases. Suppose patient is not responding. So instead of going on changing the antibiotics, you can do CT or MRI. And MRI has added advantage that there is no radiation exposure, but it is costly bit. So you have to decide. All children with community-acquired pneumonia, even if looks stable, always measure the saturation. And if child looks stable, saturation is low, there is hypoxemia, better admit the child. Role of biomarkers like C-reactive protein, procalcitonin are still not clear, so they should not be used left and right in pneumonia diagnosis and management. Low dose and short duration of amoxicillin at a dose of 35 to 50 milligram per kg per day and less than 5 days, that is 3 days, should be employed in case of non-severe pneumonia. We should not use the amoxiclav. And nucleic acid-based testing like multiplex PCR and next generation sequencing, they have role in selected cases. Again, they should not be used in all cases. And whenever you are getting the result, you have to corroborate with the lab actually. Okay, we should not unnecessarily kind of promote these tests. They have role. Again, there are some reservations in using this test also. So with this, I finish my presentation. So thank you so much for your patience hearing. And if there is any doubt, we can discuss. Thank you so much, sir. Over to you.
Thank you, Dr. Rasmi. That was an excellent roundup of recent advances in the diagnosis and management of pneumonia in children. You covered the topic very well and also management part, and you have highlighted the importance of doing ultrasound and MRI in addition to chest X-ray, which gives a different angle, because in your X-ray, in your illustration slides, we could see that even in a normal chest X-ray, we can find abnormalities when we do an MRI. So we will take the questions later after Dr. Joseph's presentation. Okay, Dr. Rasmi?
Okay, sir.
Yeah,
Thank
you can meanwhile look at the questions in the question box, and then I would like to invite Dr. Joseph Matthew, sir, to start sharing his screen and present the talk. This is a very important view on the scenario of RSV virus in Indian context. Dr. Matthew, sir, please.
Yeah, thank you very much, sir. Slide visible, voice audible?
Yes, sir. Yes, sir. You're visible.
Thank you very much.
Yes,
Thank
sir.
you. So this is about RSV in the Indian context, and very short presentation. We'll finish very quickly. So let's talk about the global scenario first. Now, globally, as far back as the mid-80s, a beautiful study was done across the world, mostly in the developing countries, 10 developing countries, as you can see. And the unique thing about this study was, unlike all other studies, we generally focus on taking nasopharyngeal aspirates from the throat and then putting them for bacterial culture. These people did look at blood and pleural fluid culture, bacteria, but they also looked at viral culture. So viral culture was unique because it's a very complicated thing to do. And the beauty is, when they looked at the data, they found that viruses actually are present in almost 1/5 to 2/3 cases, and that outnumbered the bacteria. So if you look at the slide on the panel towards the right, you can see white bars and black bars. The white bars represent the bacterial isolates. The black bars represent the nasopharyngeal aspirate culture for viruses. So the top box is community studies, the middle box is outpatient studies, and the third box is inpatient admitted children. So it is very easy to appreciate that across the board, the black bars are bigger than the white bars. So that means viruses outnumbering the bacteria. And these are countries like similar to us, Guatemala, Philippines, Argentina, Pakistan, and all that kind of a thing. So this means also that if you looked at bacteria versus viruses, right in the mid 80s, in the developing world, there was data to show that viruses outnumber bacteria. The dictum up till that time was viruses are more common in developed countries, and because of hygiene and sanitation and all that, bacteria is more common in the developing countries. And amongst the various viruses, RSV was predominant, although among the bacteria, it was pneumococcus at that time. This is now 30 years back. Then came the definitive study on childhood pneumonia etiology. This is called the PERCH study, beautiful acronym over there. And this is the largest study which has looked at cases and controls together. About 4,500 cases, 5,500 controls, age and frequency matched. And the idea was to look at children's throat swabs and a few other things like blood and pleural fluid and all that, with super sensitive methods, including cultures, PCRs, and things, to try and identify pneumococcus. The goal was at that time to do pneumococcus. This was done in 7 countries, all developing countries. 2 of those countries had 2 sites each, so it became 9 sites, 7 countries. India was not included in this. And the beauty is that when they looked at the data, this is a definitive study, like I said, they didn't find pneumococcus as much as they had expected to find. They only got it in 56 blood and pleural fluid cultures and a few lung aspirates out of 4,500. So this means basically that it is a very, very small, minuscule number. And interestingly, these sites in Asia, that is Bangladesh and Thailand, did not have vaccination against PCV, and still they didn't find pneumococcus. In contrast, the African site had pneumococcal vaccination, and they still found pneumococcus there. But the highlights is in the red part. About 90% cases and 80% controls had one of the many numerous viruses, and some children had 2 viruses, and as expected, some had even 3 viruses. Now, from this, the key thing is they concluded that you cannot identify the cause of pneumonia in an individual child. So when you pick out his throat swab and you send it off for biofire or whatever you do, you'll get multiple bugs, you'll get commensals, you'll get innocent bystanders, you'll get a few pathogenic types, you'll get mixtures of organisms, and at the end you will not know which one is the cause of the pneumonia and which one was just standing there as a commensal or a colonizer. But what they concluded is, from this kind of data, when it is done in several hundred or a few thousand children, we can calculate what is called the etiological fraction. That means, although we cannot say what causes pneumonia in an individual child, we can say if you're 100 children, then we know roughly which organism contributes to what. So these things on the x-axis are the proportions of various organisms. So it is easy to understand that the biggest contributor is RSV. See, there it is, right on top, about 33% of the cases. The next nearest is actually very far off, it's less than 10%. So RSV was 3 times more common. And when they split the data by age group, in which this inverted triangle is representing babies below the age of 1 year, upright triangles are representing children above the age of 1 year, you can see that RSV is in about 40-45% of the infants, of course about 20% of the slightly older children. In contrast, the pneumococcus, which is what they were looking for, came a far 4th or 5th, so it was still more common amongst the bacteria. It's about less than 10%. And when you looked at it age-wise, it was more common, of course, in the slightly older children and less common amongst the infants. And then, when this data was split by severity, then of course you find that RSV less likely to produce very severe disease, although it has produced severe disease, whereas pneumococcus slightly more likely to cause more severe disease as compared to less severe disease. So the conclusion from this data was that RSV is the most dominant organism in childhood pneumonia. And this was similar data to what was known in the mid-80s from the developing world. And the difference only was that time they had to do cultures, which are very difficult to do. Now they did PCRs, which are very, very sensitive. So switching gears, what is happening in India? In India, usually in these kind of presentations, we usually at this point say, well, there is no Indian data, so we cannot tell you what is going on. but that is not true because we have robust Indian data. So in 2010 to 2014 here at PGI, we launched what is called the Community Acquired Pneumonia Etiology Study. We had some funding from Sweden, and we included children with WHO IAPNRC pneumonia, same as the PERT study did. This study got concluded a little before the PERT study, but they would not publish our results because they didn't believe it. We screened more than 46,000 children and about 4,000 were enrolled. So this becomes the world's single center largest study. And we did bacterial cultures from the nasopharyngeal aspirate, blood, pleural fluid and all that. And we did multiplex PCRs also against a limited panel of bacteria and viruses. So if you looked at the bacterial isolates from blood, only 2% positivity. Again, pneumococcus was not the dominant bug, it was staph. Then the gram negatives, and a distant third was the pneumococcus. In the nasopharyngeal aspirate, of course, pneumococcus was most commonly identified. And in the BAL also, it was probably Acinetobacter, which was more common. But when we looked at the viruses, and viruses we could do in only about 40% of the samples because of the costs involved, then RSV was picked up in about 25% of those that were positive. So 1/4 of the cases were because of RSV. No other virus came even close, although rhinovirus that can be present in upper respiratory infections as well came a distant second, and then everything else was quite minuscule. The bugs in red, these viruses are the ones which are traditionally called pneumonia pathogens, because the belief is that if they are picked up from the throat, then the child is probably suffering from disease as compared to the other viruses which are lower down. So you can see that RSV has been the lead. So the big conclusion from the CAPE study as far back as 2014 was that viruses outnumber bacteria. So if you look at this text in red, what you will observe here is that among the 30% of children in whom etiology could be definitely established, and we say definitely because it means either it came in the blood or in the pleural fluid, or there was a single isolate from the throat, which was not a combination of 2 or more organisms, and these 4 pneumonia viruses, then about 18% of the cases was viral, 12% was bacterial. So viruses outnumbering bacteria by 1.5:1. And among the babies who had Bs, of course, they were more likely to have RSV, and that is not unusual because some would have had bronchiolitis. So the big conclusion was that viruses outnumber bacteria in a developing country, in India, not pneumococcus, mind you, and RSV is the important one. But 2014, incidentally, is the year when we jumped onto the bandwagon of immunizing children with PCV for entirely reasons other than the scientific thing. We expanded this study further with what we call the phase 2 of CAPES, wherein we looked only at children with severe and very severe pneumonia, hospitalized one. We excluded children who had taken any antibiotics, because one of the criticisms of all these studies, PERCH and ours, was that if children take antibiotics, the pneumococcus disappears. So non-isolation of pneumococcus doesn't mean that it was not there. Maybe the antibiotics cleared it. So to test this hypothesis, we looked at children who had not taken any antibiotics. And in this study, we did multiple samples, blood, nasopharyngeal, pleural fluid, BAL, lung aspirate, and all that wherever it was possible. And we did cultures and viral PCRs on all of the samples. And then, because it was this is part of my PhD work, so it is a limited sample, 222 only. So depending on how we defined etiology, we used firstly what is called a liberal model. A liberal model means any bug you pick up anywhere is taken as pathogenic, unless it is as group A, hemolytic streptococcus and those kind of things. So if you looked at this column, what you see is again viruses outnumbered bacteria, 2:1, same ratio, 1.5 times viruses as compared to bacteria. And because a lot of them are mixed, so you can't make out what's happening. Atypical organisms, very few based on serology, and majority indeterminate because you don't pick up any pathogen at all. If you looked at an intermediate model, which means you start removing some of the organisms as being query pathogenic, so you'd start taking out things which came up only in the nasopharyngeal aspirate, not in the blood and all that. Then you make the definition of etiology. Then again, you find it is viruses which are outnumbering bacteria. Second row in the red color. And if you looked at a highly conservative model, which means the robust definition of etiology, wherein you remove all the bacteria from the nasopharyngeal aspirate as being pathogenic, and you remove all the viruses except the 4 pneumonia-causing viruses, then you see the bacterial numbers plummet down and the viruses are now about 6 times as common as the bacteria. So there is no doubt that viruses outnumber bacteria even in countries like ours. And proof of the pudding is also that Gates Foundation has some data which they have never published, but which they disclose in meetings, which shows that even before the first dose of PCV was administered in India in 2014, pneumonia burden had come down by 60%. And that was to do with better quality of life, better routine immunization, increased breastfeeding rates, and so on and so forth. Now, if you look at this, it's a little confusing picture. The vertical bars represent the 3 etiology determination models that I talked about, and each of the horizontal colors represents one pathogen. So if you looked at this broadly, don't try to read the names of all the bacteria and viruses which are in the rightmost extreme. You can see that the dominant color is yellow, that is RSV. The next dominant color in the first 2 bars is pink, and that is a combination of bacteria with virus. So that means there will be a combination of RSV along with some other bacteria, so you don't know which caused the pneumonia. The pure RSV, if you look at it, is in the yellow section. So we know from this study, unlike CAPES 1, wherein we said that RSV is important, now we have clinched in 2015 that RSV is dominant in India. And of course, the West would not agree to publish this because it was going completely against the pneumococcus as the big deal kind of hypothesis. Now, based on this, the ICMR initiated a multicentric study because this data was kind of an eye-opener for them. So they decided to replicate the PERCH methodology to try and do a case control model of study, again with the intention of hoping to find pneumococcus and justifying the pneumococcal conjugate vaccine. So 5 sites, big cities, 1 in each geographic area, case control design, 1100 cases, 1100 controls, blood nasopharyngeal aspirate taken in the cases, only nasopharyngeal aspirates in the control. And our site ended up enrolling about 30% of the total because we were used to this kind of a thing. So even though each site was to enroll 220 cases, we had 314 cases and 314 controls. And this is what the data looks like in the 314. Now, please focus on the color of the bars. The red bars represent the organisms isolated in the children with pneumonia. And the green bars represent the organisms in children who didn't have any symptoms. Age and matched children, but no pneumonia, they are healthy children who came for immunization. So higher the red bar, more likely is it in pneumonia, and green bars are the ones which are in normal children as well. If you look at the bacteria, the 4 dominant bacteria from left to right, pneumococcus, H. flu, Staph aureus, Moraxella, you can clearly see that they are pretty much similar between the cases of pneumonia and the controls. Whereas if you look at the dominant color, which is the organism wherein the red bar is way, way, way higher than the green bar, it is RSV, influenza, parainfluenza, HMPV. And the RSV is dominating. So 1/3 of the cases has got RSV. If you did some statistics on this, then you find an odds ratio which suggests that if you picked up RSV in the throat of a child, is 7.3 times more likely to have pneumonia as compared to being a commensal. Whereas Staph aureus, pneumococcus, the other way around, more likely to be picked up in children who are healthy than in children who have got pneumonia. Now, if you split this data age-wise, so what happens is this is babies less than 6 months of age, same pattern. So RSV dominating like anything, and everything else green in the bacterial side, green more than the red, which suggests, except for H. flu, that they are more common as commensals. Again, the odds ratio very significant for RSV, not significant at all for Staph aureus and S. pneumonia. Between the ages of 6 and 12 months, you can see now that the bacteria in the cases and in the controls are going neck and neck, whereas RSV continues to dominate, and now you can see other viruses showing up, especially the parainfluenza virus. So the odds ratio again very, very significant up till the age of 1 year. When we go beyond this to 1 year to 2 years age group, you can look at the first 4 columns, which are the bacteria, similar in cases and controls. Whereas if you look at the viruses, now RSV is still dominating, but the height of the bars has come down. Influenza showing up, parainfluenza showing up, HMPV showing up. So in infants between 1 to 2 years of age group, RSV is still dominating, but the other 3 viruses are also important causes. Beyond the age of 2 years, things are settled down somewhat. You can still see the bacteria, no significant differences between cases and controls. RSV is still present, Influenza now taking over, and by and large, the RSV bars have come down in size. So what does all this mean? That RSV is definitely the main etiology of pneumonia in Indian children, especially the younger infants. And that is not unusual to expect, because some of these would have bronchiolitis-like thing, and they would have pneumonia secondary to that, or even otherwise. So that is the data, the science behind whatever has been shown. So let me now very quickly sum up all this in a single slide by telling you RSV in the Indian context. Now, from the science perspective, there is no doubt from the mid 2000s that RSV is the most common pathogen causing childhood pneumonia. This is well established now, especially if it is infants below the age of 12 months, but up to 2 years also it might work. But beyond 2 years, probably it is other viruses also coming. But interestingly, this information is not new. This is very well known for the past 10 years. Probably if people had done studies before that robustly, it would have been picked up at that time. But we know that it is currently also the same story. Unfortunately, there never was, and there still is not a solution to this problem, because there is no vaccination for RSV. We'll get one in the next 8 to 10 years. And as usual, when it comes, those who need it will not get it. Those who get it probably would not be needing it. So that is the kind of story which happens with vaccination, which comes in before the scientific studies have been established. That is the science in summary. Now the commerce. In recent months, some products are now available for targeting RSV, they say. One is a monoclonal antibody, which has been prevalent in the West for several decades. They use it to a subsegment of babies like preterm and cardiac disease and this and that. So it is probably now coming into India, or probably is already here. So the marketing reps will run after you and say, okay, this is available now, you must give to things like that. But please remember one thing. The 3 subgroups where it is so-called recommended for in the West is extreme preterm, children with congenital cardiac disease, and of course, children with immune deficiencies and things like that. So we have to ask ourselves, what is the probability that one of these 3 groups of children will reach the age and stage at which he'll get RSV and die of RSV, rather than his basic problem of prematurity or cardiac disease or things like that? And then the answer will become very clear that it is something which cannot be used liberally across the field. There is another very expensive monoclonal antibody which has come up. I think some licensure studies are being done in the country. Our institute was invited to be a part of it, and I flatly declined, because there is no research in it. It is only to help the company to commercialize their product. So both these monoclonal antibodies has no scope in India currently from the public health point of view. So I'm mentioning this only because the company reps will now start meeting you, and they'll start showing you this novel data. Look, pneumococcus is controlled. RSV is the main bug in our country, at which time we should be empowered enough to tell them, sorry, that information is completely wrong. RSV it has been well known. Pneumococcus has not been documented to the extent that RSV has been. So there is nothing new, except that the product has come which has to be sold. And my final key message is, about decades back, all of us in this room or this audience chose to take the science branch, after our 10th standard board examinations, and not the commerce branch. And so that is why we are sitting where we are today. But those who have pursued the commerce branch are the ones who are now trying to convince the science people like us that they know more science than we do. But actually, that's not the case. We know both the science, we can also perceive the commerce, and these are best kept like 2 railway lines. Let the tracks run parallel, but let them not intersect, because when the intersection happens, that is where the problem begins. So on that note, I want to thank Chairperson Sir and IAP President, Professor Dr. Kalpanavar, and also incoming President Dr. Rawat, and my close pal, Dr. Jagdish Goyal. And I'm happy to take any questions if people want to ask. Thank you.
Thank you, sir, for this excellent and concise brief presentation, which highlighted the present problems in treating RSV and the difficulties in using the monoclonal antibodies. So, Dr. Jagdish, should I take up the questions from the question box?
Yes, please, yes, go ahead.
So,
Dr. Rashmi, I'd like to ask one question. What is the superiority of MRI over CT scan? Like if you compare CT scan versus MRI in pneumonia, which is more will give more information?
Sir, MRI may be equivalent or better, but only thing is that radiation exposure is less, and in MRI you need to sedate the child. So that is the problem. Otherwise, it may be equal or better, at least not worse than the CT. So added advantage is the this one, no radiation exposure, but again cost is high, and you have to sedate the child.
Then like a question, I'll start Dr. Matthew. As you are telling, and now the data is coming that viral etiology is very common and one of the important cause of pneumonia. So when you decide to treat a non-severe pneumonia in OPD, so is there a possibility of wash rating and not giving antibiotic? Because again, we would be giving a lot of antibiotics to children who are not having bacterial pneumonia. So is there any evidence, is there any data which indicate that we can treat non-severe pneumonias in OPD by
Yes, sir.
vaccinating and not giving antibiotics?
Yes, sir. And the proof of that is when the treatment for pneumonias was started, oral antibiotics, it was 7 days. Then people tried 5 days, that also worked. Then people tried 3 days, that also worked. People tried 1 day, that also works. And the reason why these things works is majority of the children in both the groups, the shorter antibiotic versus longer antibiotic, don't need any antibiotics. So because they are forming part of the group, you will end up with comparison. And if somebody does a study of no antibiotics versus 10 days, then also you'll find it works. And the reason is simply because viruses there is no role of bacteria, antibacterial, number one. Number two, the definition of pneumonia is made such a way that a lot of other conditions which are not pneumonia will also be picked up. That is why the WHO later on had to say that if you're seeing a wheezing child, give 3 rounds of nebulization. If the wheeze clears, don't count him as pneumonia, so on and so forth. So it is very likely that we can get away with a lot of no antibiotics.
Then when we decide to treat a child with pneumonia above 5 years, again, there are a lot of data which is coming that atypical organism, mycoplasma is one of the commonest evidence commoner than strep pneumonia. Some say that first is commonest is mycoplasma, followed by viruses and then strep pneumonia. So again, are we justified in treating a child above 5 years primarily with macrolides rather than starting with amoxicillin?
So there is no data in our part of the world which shows that mycoplasma is an important organism for childhood pneumonia. There is data which comes from China. For some reason, in China, it seems to be very common, and they do a lot of studies specifically looking for mycoplasma. So in the Indian series, mycoplasma by PCR has come up in up to 1 to 2%, chlamydophilia in less than 0.5%. If you do serology, which is non-specific, then it can come between 2 and 5% also. So empirically, in the combination of antibiotics used before cultures are available to treat pneumonia, there is zero need for giving any kind of macrolide and azithromycin and those kind of things. People tend to give it, but it's not a wise idea. The other reason why it's not a wise idea is azithromycin is now our last resort for MDR typhoid. Typhoid, we have got plenty in our country. Our neighboring country was using azithromycin liberally. So when they were hit with MDR salmonella and their azithromycin didn't work, so they were in deep soup. So if we use azithromycin irrationally, we will also end up in that same boat, and then we will be stuck because it's very much required for salmonella. Thank you.
Okay, sir. Suppose a patient comes with clinical signs of pneumonia, we find cavities in the both sides. So, as per your data, it has been seen that mostly these patients are mostly viral. But can we, in the OPD or in the clinic, can we use procalcitonin to differentiate between viral? If
No.
okay.
No, we have tried tested procalcitonin extensively.
Right.
We have looked at this, we have done years back when
Okay.
everybody was hyping and saying procalcitonin is good. So the summary on procalcitonin is very simple. When you see a child who's clinically no doubt bacterial, which means highly toxic, pustules here and there, pneumatoceles in the chest and all these kind of things, where you don't need a specific test, the procalcitonin levels are very impressive in them. But where you need it the most, children who don't have those dramatic signs, their procalcitonin is kind of 50-50. It's like tossing a coin. So neither CRP nor procalcitonin will help. It'll give you some idea if there is sepsis going on, but it won't clinch and say, now the procalcitonin is this much, therefore you should treat with the antibiotic or change the antibiotics for water. It is best to go with clinical judgment and monitoring of the child.
And Dr. Rasmi, would you like to comment on that procalcitonin?
Which one, sir?
Procalcitonin.
So we have shown that, sir. I will agree with sir. So it should not be used as a kind of upfront test. And suppose you have done it, it is high and it is decreasing. Then, but again, it is not clear how much decrease over what period of time. So better not to use, because once you start using, you will get confused and ultimately there is no endpoint in using this test actually.
Okay, all right. So I will go to the questions that have been is open. A few of the questions have been answered. That is by both by Dr. Matthew and Dr. Rasmi. That I won't take. So first question is to Dr. Rasmi. What are the indication of NGS in case of community pneumonia? We have already, I think.
Yeah, we are not using, sir. So suppose you are not getting anything, you can use, but again there are limitations, and if you get multiple organisms, you cannot tell which one is responsible. So those are not kind of, I don't think that is useful for common. So rarely you can use, but again you have to interpret in that context. That is the problem.
There's one question for Dr. Joseph, sir. That is role of pembrolizumab, and can pembrolizumab be used for therapeutic purpose in immunocompromised patients not responding to ribavirin? Doctor,
see, we have to understand this. Pembrolizumab has got 3 or 4 indications from the Western literature. Extreme prematurity, children with congenital heart disease, children with immunocompromise. Why?
Yes.
Because the children with these 3 conditions survive to an age that they get RSV, and the RSV hits them so badly that they end up with ICU, ARDS, death. Now, if you are treating children like that your preterm babies are surviving prematurity and hypoglycemia and intracranial hemorrhage and all those complications, and coming out to the age that they are getting RSV and dying because of that, then it makes sense giving pembrolizumab. But in India, by and large, babies are not going to be surviving to that level. Huh? A baby with congenital heart disease is dying because of his untreated heart disease, not because of RSV and ARDS because of RSV. So in a niche setting, wherein the babies have gone through all these things and come out, yes, these monoclonals might help, but we cannot have the same blanket recommendation in our country as in a Western country, just because the epidemiology is quite different. I hope this is making sense. And pembrolizumab and this nirsevimab are the 2 things for which people will be now after you. And I don't know whether you will see it in this Respicon and this Pedicon, but soon you will find sponsorships of every session that RSV is the new bug which has been discovered. Here is a treatment for it. Please be very wary and cautious. That is why I requested Dr. Goel that we will talk about this. To forewarn is forearmed. So let our community be, forearmed and forewarned about the strategies which commerce will use. Yeah.
So there's a question on can oral ribavirin be used in undocumented RSV pneumonia in children with comorbidities or immunocompromised states?
Yes. So in all these children wherein the risk of death because of RSV is high, so all these things will have some room. But that is for us to determine how much is going to be the risk of a child dying with that versus the condition which is got. For example, if there is an immunocompromised child today, let me assure you, he is more likely to die of bacterial meningitis, some Pseudomonas pneumonia, not really RSV related pneumonia, ARDS and this thing. So that is the toss-up. In the West, because they're able to control the bacteria and things like that, their children are with SCID or primary immune deficiency are not going to go and get staph disease. Our children are getting that. So RSV is important, no doubt. But if you look at the proportion of organisms out of which these so-called immune-compromised children in India are affected, and severe disease, ICU admission and death, then it is bacteria and fungi.
Right.
Whereas in the non-immune compromised, virus outnumbers bacteria.
Yes, in the immune competent or the patients who don't have immune compromise, they basically with RSV infection will recover with conservative treatments. That's the message we should give, sir. So, Dr. Rasmi, Dr. Sami is asking how common is bronchospasm in pneumonia?
Yes. Okay, that's to Dr. Ashwin.
Yes, sir. So it can happen, but as I told, so you have to give 3 doses of nebulizer and see. So if
Right.
it's disappearing, then it is because of that, and if it is not, then it is because of pneumonia. So
So
that
basically, wheezing will be more in viral pneumonias, bronchi and wheezing.
percentage,
Yeah.
that is a number, but again, given context, given cell, very difficult to tell. So it can
Right.
happen. Keep in mind, patient not responding nebulization, so it may be because of pneumonia. So we manage like that.
Okay. So the another question is role of oral ribavirin. Dr. Jafis already answered. Dr. Asmi, what to do if there is a persistent chest signs even after 5 to 7 days of treatment in amoxicillin?
You have to, I told na, so you have to do kind of advanced kind of testing, like imaging you can do, ultrasound you can do, and there may be some complications. There may be electric band also. So you decide that there may be something. If you're getting chest and crepitation is persisting, as I told, in X-ray it is normal, but you are this one in MRI you are getting, you may do CT, ultrasound. So ultrasound you can do because that is radiation free. So that can largely detect the pathology. Suppose it is not detecting, still you are not getting, so then you can go for CT MRI. So then you have to see whether there is something inside. There may be complicated, like kind of congenital anomaly. So that has been infected. Now it is cleared, but that's this one is persistent. So something leading to persistence, you have to find out the cause actually. It may be bug which is kind of resistant. It has partially responded. It may need another antibiotics or longer course. So all these you have to see in the given context.
Okay. Okay, so one question, Dr. Joseph is also typing the answer. Again, by Dr. Samir, sir has said in the presentation, antibacterials have no role in the viral pneumonia. That is okay. But Nelson mentions there's risk of secondary bacterial infection. What you recommend? Would you recommend prophylactic antibiotics?
No. There is no scope for prophylactic antibiotics except in immune suppressed children.
And his question is basically, when do we start antibiotic? In the case of pneumonia, not responding 3 to 4 days, when in the clinic, when do we start oral antibiotics?
So when we suspect that there is bacterial infection, fever is not coming down, child is toxic, clinical signs have not abated, and the 3-4 things which we monitor: respiratory rate, oxygen demand, overall well-being, appetite. If these 4 things have not improved, then you know something is going wrong. By the time the cultures will also be available, we will be justified in starting antibiotics at that time.
Right. Thank you, sir. And so there's a question on should we worry about pneumococcal subtype 19A in India, it being resistant to amoxicillin and ceftriaxone, and choose vancomycin settings where there is no response?
Blanketly, like those data has to be so okay, like some 1 study, 2 studies showing. So you have to be careful, and we should have the region specific data. So blanketly very difficult that resistance has appeared, you switch to this antibiotic. So not like that. So every case has to be managed differently. As I told, setting you have to see condition of the child, risk of particular infection. All those you have to take in account. There is nothing that you start this, then not like this, you change to this, that. There may be something which is mechanical that is persisting, that is causing persistence. So those things have to keep in mind, and you have to see the patient as a whole rather than jumping, just changing the antibiotics, not responding. Or in one data there is a high resistance. You should see also what is happening throughout the India. Those we have to be careful. So blanketly, single study that should not change the recommendation or should guide something actually.
Right. If we are in a big institution, in a private, or suppose in a big hospital, in a medical college, we should be aware of the antibiogram. That is the
Every
sensitivity of the law. Yeah.
hospital, whoever is managing,
Right.
you should have data on your IPD patients, ICU, because what we see in the inpatient, the ICU data is different. In our hospital also, we should keep, so that will be the best guide in all cases, not only pneumonia, in all cases, if you know what are the organism your hospital is growing and what are the sensitive pattern. In fact, now we are using Ceftriaxone because even the Klebsiella, Acinetobacter, whatever is growing in our setup, they are sensitive. So now we are using left to right because almost 50 to 60% are sensitive to the Ceftrian. So Ceftrian in other setting, it will not be used. So if I tell that use Ceftrian in case of this MDR organism, which is kind of resistant to other, people will laugh because why Ceftrian? So that's why every hospital should have their own data rather than telling that you use this after that. There is no rule of thumb actually. Your setup may be different from mine. Mine is different from search. So like that. So we should have the data, then we should kind of apply.
Yeah, so to know this data, you should collaborate with your microbiologist to get a monthly data of your sensitivity. So
there is a question on, I think, resistant. If suppose microbiology resistant to azithromycin, you can use tetracycline, fluoroquinolone. So these are the options.
Joseph sir, I think has given the answer.
Yes,
We don't have robust data on azithromycin
resistance.
Yeah.
There's one on Sabba. I think this will be more of a asthma type of question, so we will about this. So I think any questions left, Dr. Jagdish?
No, I think means expert have answered all the questions in question answer chat book also, and you have also taken the question. So I think we have exceeded the time also.
Yeah.
So on behalf of IAPNRC, I would like to thank our both experts, Dr. Joseph Matthew sir, for speaking on very relevant topic, RSV in Indian context, and Dr. Rashmi on recent advances in management in pneumonia. And thanks to Dr. Mrityunjay also for nicely moderating the session. And thank you, Rawat sir, for joining us and all the viewers. So just a small announcement, those who are still not registered for Respicon will be going to be held from 22nd to 24. So you can go on Respicon website and register. So hope to meet you all in Davangere in Respicon. Till then, thank you. Bye-bye. Good night.
Good night all.
Thank you, sir. Good night, sir. Bye.
Thank you, sir. Good night, everyone.
Dr. Joseph and Dr. Rashmi for the excellent presentations. We'll meet you again in Davangere. Good night. Good night, sir.
Everyone is coming. I think sir is coming. Joseph sir is coming. Everybody is coming in the.
Yeah.
Everybody is up.
Bye.
Okay. Thank you. Good night, sir.
Good night. Good night, sir.